Yeah, I came from cold Boston to a rainy Switzerland, but that's better than what we've been having in Boston, with some temperatures have been below -20 for several days in a row. So fortunately, we all stay inside and work on things like this. The problem that we're trying to solve is that we need cohorts of patients that need to have two things. They need to be patients who comply with specific kinds of questions that we want to answer. So like all patients who have asthma, all patients who have rheumatoid arthritis, all patients who have pancreatic cancer. And then we're going to want to use that patient population to help us answer how to manage them, right? Because it turns out that, for example, in asthma, we can use the genetics of the population to divide them into two groups. One which responds to steroids, and one which does not respond to steroids. And that then helps us, that subpopulation stratification allows us to do those evidence-based treatment protocols so that we can manage our patients and the medicines we give to patients and the surgeries we give our patients much better. And of course, then we can, this is all based on our predictive analytics that can be increasingly complex about how the patient's going to fare in different treatments. So all of this, though, starts with this kind of problem, which is we need to get enough patients to do what's the equivalent of a clinical trial. Now, sometimes it's an actual clinical trial, and other times it's what we call kind of a pragmatic clinical trial, or an observational clinical trial, which is we just use how they're being managed in clinical care in order to gather this information longitudinally. And I'll show at the end of the talk how we can infuse this work back into clinical care so that we can actually have this continuously evolving, put it back in clinical care, see how it works, and then do another experiment, and then go back into clinical care again. So here, we are interested in the PPAR gamma gene, which many of you are probably familiar with, because with diabetic medications, this turned out to be the key, right? It's how the nucleus expresses certain kinds of proteins, and it varies by this variant called the Pro12 variant. And what you see here is actually a bunch of clinical trials, and this is increasing sample size, increasing number of patients in the cohort of the clinical trial. And this is the determination of whether that variant is protective, or that is, it protects against diabetes or causes diabetes. And some very early studies showed it might be protective. But you can see that the error bars are so large, so you really couldn't make any kind of determination. And then, as the studies got bigger, it got a little better, and the error bars got a little smaller, but it even ventures over here, and you can see that that's, of course, statistically what's going to happen, right? Because that's what error bars mean. Error bars here mean that you don't know whether it's protective or causing diabetes. And it wasn't until the studies got very, very large that you actually could determine that it was protective. And once it was determined it was protective, then all the glipturides, for example, got invented, and those are the major medications that are used in diabetes today, or one of them. So how can we support high throughput methods in translational research that can carry this process through faster and faster, especially as the informatics tools are enabled so that we can collect the data, sample the patients, and that process. And so what we looked for was this method, and we settled on the following. So we invented tools that allowed you to select patients from the medical record in a high throughput fashion, so that the investigators could get their hands on the tools and actually go and use the tools themselves to find the patient populations that they needed. Because it turns out that when you look for a patient population that you're going to study, you kind of go back and forth in your mind as far as like, do I want them to have high sodiums or not? Do I want them to all be within a certain age range or not? And without a dynamic way of querying the population that you have to see if you have enough patients, right? This whole goal is always to get enough patients in your study. You're going to be kind of in the dark. You need somebody to query the medical records to find how many patients you have available for your study. Now, once you have your patients available, you need to be able to explore the phenotypes and do your analytics. And it turns out that's very, very difficult. I'll just show you a few reasons why it's so difficult. But so we developed this tool to query patients, but also a way to actually focus in on very specific attributes that patients could be derived from the medical record. Lots of things can't be derived from the medical record, by the way. A lot of data is just too raw and too error-prone in the medical record to be of any value. But that's not true for all data, and you can do machine learning to improve it. We'll show you that. And then once you get that working, you can increase your catchment area of patients and the availability of data by 3 succeeded methods, which are particularly important for rare diseases. And then finally, we deliver the data that we derive back into clinical care in order to improve clinical care and set the next set of questions. So how do we go about querying this in a high throughput fashion? So we invented something at Partners Healthcare called the Research Patient Data Registry, which was the beginnings of an international project called Informatics for Integrating Biology in the Bedside, or I2B2. The requirements were that we needed to build a tool and allow investigators to get access to a database which had all the phenotypes from the medical record available. So we put together all the in- and outpatient clinical data, 6.7 million patients, 2.5 billion attributes of patients. Their diagnoses were, medications they were on, laboratories that were done, demographics, genomics, and so forth. And then we authorized the use of the tool by their faculty status. We use that to establish kind of a method of trustworthiness. So there's a combination of trusting the user and not allowing the user to see more than they need to do a specific task. That almost always has to come together in scenarios like this to minimize the risk. Because the institution, Partners Healthcare, is taking a tremendous risk making this tool available because of two reasons. One is that somebody might try to use this tool to focus in on one patient, and with all this very rich data, that's going to be possible unless you have some data obfuscation built in, which we do. And the second risk is that folks will go in and query something to get to the news, right? Because they want to be famous, so they want to find out how many abortions are done in underage patients, for example, at one of our hospitals. And so there's both a political aspect to this and a privacy aspect. And this trust relationship turns out to be very important. So we authorize people to use it by their faculty status, that is, are they professors or assistant professors or instructors in the university? And then also, they can then delegate to all of their fellows, their graduate students, their research assistants use of the tool, and they look over that use very carefully. So it's a way to push trust. And then we give this trust in two steps. So first, you can use the query tool, and I'll show you a lot of detail about this later, to construct cohorts of patients. Find just how many patients are there who have pancreatic cancer and also have breast cancer. And then once you know how many patients there are, you know whether a study of the interaction of those two are possible. Because you'll do this without getting explicit approval. We had to get approval to build this tool and make the data available this way. But you don't need explicit approval just to use the tool and find out what the counts of patients are. But you do need explicit approval when you're going to return identified data on the patients. And at some point in a study, that's almost always necessary because you're going to have to go into lots of details in the reports of those patients, the pathology reports and the clinical notes, and those are almost impossible to de-identify, despite the many tools that we and others have tried to build over the years. There are some very specific problems with how you can de-identify a note which has laden with different kinds of numbers, microscopic slide numbers and so forth. That makes that a very difficult process. And that means that they're going to have to almost always be exposed to identified patient data, also to recruit those patients, right? A lot of times we want to recruit them for a trial, or we want to get in touch with them so we can ask them more questions. So at that point, we do something called, we write what's called an IRB protocol. So every hospital has an institutional review board, which you have to go to if you want to get identified data on patients. And they have to approve you. Basically, they're saying, is the question that you're asking worth the risk that it's going to pose? Now, usually the risk isn't that high because you're only talking about 2 or 3 well-known investigators who are going to see the data. Right? But they're only going to see the data on patients with pancreatic cancer and breast cancer, right? No other patients. So we reduce the risk as much as possible, and then we reduce the number of people who can look at the data. And at that point, we do return the identified data to those people under very secure circumstances, information security, that allows them to look at all these different things. So both their data about their providers, data about all of the structured diagnoses and medications and reports and so forth, as well as imaging and genomics. So we do things in these 2 steps. First, a large number of people at the institution can now get access to see if there's enough patients for a cohort and to do a study and do some preliminary data to get grants and so forth. And then we can return detailed data on those patients to do the study. So in order to do step 1, find cohorts of patients, we invented this query tool where over here you can select what you want to ask about the patient. I want the diagnosis of breast cancer and I want the diagnosis of pancreatic cancer, for example. You open this tree and fill it in. And then over here is where you build your query. And you see you have some boxes, and that's our programming limited way of making circles, because we're trying to be circles of a Venn diagram. And so if you put 2 items in this circle, they'll be logically ORed together. So if I put pancreatic cancer and breast cancer in here, I would find all the patients who had pancreatic cancer or had breast cancer. That might not be what I want, but that's what I would get when I hit the run query button. If I want the intersection of the 2, I put pancreatic cancer in here and breast cancer in here, and then I say run query, and then I'll get the results. And so it looks like this. So here's a patient where I wanted to know if they had ever had their EGFR genome. So EGFR is the epithelial growth receptor. It's very important in different kinds of lung cancer. So you can determine what kind of chemotherapy to use now because of this variant. You can see these are the rare patients that had their EGFR gene genotype. And then here's all the patients who had respiratory cancer. And so this is saying I want all the patients who had respiratory cancer and had EGFR done. You can see there's 269. Then you see this plus or minus 3. And like, boy, they got plus or minus, that's the error in the system. The answer is no, that's not the error in the system. The error is much, much larger than that. If you reduce the error would probably be like plus or minus 100, at least. That's just the amount of purposeful obfuscation that we introduce. So we blur this number, whatever this number really is. It might be 270 really. We take a random number in a Gaussian, the sigma happens to be like 1.6, and it gives you, and we'll add that randomness to this number to create a fake number, right? And you know it's within about plus or minus 3 from the Gaussian tail. But it's a fake number, and if you do the exact same query again, you'll get another number, 271. You do the exact same query again, you'll get 268. And you'll keep doing it, and you'll see that eventually that will converge, right? So if you did it 100 times, you could just, write them all down and average them up and you get the right number. But when you reach 7 repeats of the same query, it locks you out. And this is a lock here that turns red. And so that's how we prevent people from focusing in on very specific numbers. Because if you get specific numbers out of this, you'll be able to mix them up to the point that you'll be able to find a specific feature. Once we do that query, we get that number, now we go in and we say, okay, we'll give you the detailed data, but give us your IRB number, right? Now, IRB, by the way, is no small process. So usually it's about a 20-page application. So you want to know, before you set out on that 20-page application, if you have enough patients. You don't want to do a 20-page application and find out you have no patients, right? So, but we ask you, we go through this wizard, what's your IRB number, what hospitals, some different hospitals have different IRB numbers associated with them, and you need to list them all. And then we will gather all this data together for you and return it in a database. The data all has to stay at the hospital, so none of it can go outside of the hospital firewall. All has to stay within the hospital. And we actually have built a analytic structure at the cost of about $30 million, so people can actually just keep this data in our own data center. It's kind of like a data enclave. Now they don't have to. But some people have other data centers that they built, and that's okay. But they all have to be certified, and in that IRB you have to describe where they're going to go. The same concept applies to the Partners Biobank, where we actually have 80,000 patients now. So data, I forgot to update this one. And but they go into this biobank, and in the biobank we give the data in exactly the same kind of a portal, and all of this data with it. So we do genotyping on the Illumina Omega array. We get 1.7 million variants. From there, we do the transcriptome and look at things like methylation as well. And then we put the data all together into a common system, and we make it available in a portal that's going to utilize I2B2. So I2B2 is this software that we can, for explicitly organizing and transforming person-oriented clinical data so it's optimized for clinical genomics research. So I2B2 was built using US government funds, so it's all open source. And it allows you to combine that query tool where you explore the phenotypic data with the genotypic data of the patient and any survey data you have as well and so forth. So any kind of biometric data about a patient you can put into I2B. And it's extensible. So it's built in a modular fashion so that all the great ideas that we never had when we put this together can be put into this package. It's all available at this website. And these are called community projects, which allow you to do these extensions. So for example, we never knew fire was going to be so important, right, to do fast healthcare interoperable methods. But now people can build new cells that allow you to add that modularity. And so we have a lot of things going on in that space. And then we have ways of building things called loyalty cohorts, where we know patients are true to the hospital, so they get all their care at the hospital, which is important for epidemiological studies, and so forth and so forth. And there's about 50 of these. And they all add in as modules to I2B2. We call it module cells. And the environment ends up looking like this, where you have the data packed into a star schema. So if any of your database experts, I can summarize it all and say it's a star schema, right? It's an entity value attribute database. And it allows you to express all of this data using this multidimensional approach. And new cells can be added to this environment so that these cells are like a de-identification cell, we have a natural language processing cell, we have a project management cell. All of these can be added in here so that the user gets this experience, which is just to use a simple query tool. It's very important because this project is to allow researchers, not information technology folks, right? Not us, right? People who are in the biology, in the clinic, to use the tool. So all of this complexity that you would build, for example, into one of these modules gets expressed so that the clinician and the researcher can. And they kind of all come together in what we call a hive. We present all these different tools. And there have been many implementations. It's actually out of date, but I still use this slide because now it wouldn't fit very nicely at all. We have about 200 instances now, implementations, but it continues to be very important that we have all these implementations because we're going to tie this together into a network, and we'll see that in a little bit. The query tool you see from I2B2 looks very familiar. Here you have your, where you find the terms, and here's where you put together your queries. You have a few other things like the concept of a workplace of patient, so that people can share their data actually in the tool. But we can extend the tool further because this tool, I2B2, doesn't only allow you to do obfuscated queries. It also allows you to do different levels of permission. So you can be an obfuscated user, and most of our users are, right? They can only do those obfuscated queries with the blurring of the number. But then you can also have a limited data set. So in the US, the limited data set means that you can have line item data. So you can look at line item data, and you can see dates. And dates can be very identifying, so you have to be very careful with dates. But in this case, this person is allowed to do the dates. And here, you can see they looked at timelines on each patient. So each of these yellow bars is one patient. They're looking at one patient at a time. You can't do this if you're an obfuscated user, but you can do this if you're a limited data set user. And they're looking at a timeline of when they got bronchodilators and when they got prednisone. And it turns out you can't ask the system, I want all patients who are resistant to prednisone for their asthma, because the concept's not invented yet, right? Some investigator just thought it up. But you can use a display like this, which says, okay, when they go to the emergency room, are they getting their steroids or not? And so in this case, this is when they got bronchodilators in the emergency room, and here they got prednisone every time. So this is a good patient. They're probably responsive to steroids. This one came back in the query that said they got bronchodilators and prednisone, but you see, they don't get prednisone. They got it here once, probably for poison ivy, something like that, right? And then here we have too little data, actually, to make a determination. So this lets us take some deep dives into patients and patient data, and that turns out to be very, very important because of the following problem. So the problem that we have to solve as well is much of the data that's in the electronic medical record is inaccurate. So this is a receiver-operator curve. The receiver-operator is specificity versus sensitivity. And if data is completely random, just toss coins and plot it here, it will give you this diagonal line. So we looked in the medical record to see if a patient who we knew had the diagnosis of depression was given the diagnosis of depression in the electronic medical record, and the patients we knew did not have the diagnosis of depression were given the diagnosis of depression in the medical record for a specific encounter, and it looks like this. So for depression, it's almost a guess, and the very specific numbers, 54% predictive value, right? If they have a diagnosis in the record for billing. And that's most of the diagnoses you get, are the billing diagnoses. Very poor. You can't find that to do genomic research, but you know you have lots of other clues. You have, did the patient have, were they on a medication used to treat depression? Did they have electroshock therapy? Did they get written in the note by the provider that they had depression? And when you do that, and you explicitly look at with natural language processing and so forth, you can greatly improve the accuracy of your diagnosis. And so that's the technique. We'll use all this data, right, in order to do that machine learning. So we do natural language processing and all this different to classify our patients by this kind of standard method of gathering a gold standard of patients. So let's say you have 100,000 patients who might have depression because they have an ICD-9 code for depression. We'll take 300 of them, divide them into what's going to be about half and half, right? We're going to have depression and not have depression. We're going to pull out features that seem, what we think as clinicians are important to say a patient has or doesn't have depression. And we're going to pull that out for all 100,000, but we're only going to compare using a logistic regression to patients that we know really have depression. How do these features fare? And we're going to fit them. We use like what's called the lasso or elastic net also, but different techniques. And using this way of doing machine learning, right, to fit those features that the patients have in the medical record. But all the features, not just their diagnosis and billing diagnosis. With this regression algorithm, we can get very, very good specificity. And that's then possible to use for genomic analysis. In this case, we use it to find that using their scans, their MRI scans, it shows what have something called tensor imaging, that the white matter, the white matter tracks, so the person who's resistant, who's treatment resistant, they have depression, so we know they have depression because we just did that algorithm, but they're resistant to their medications. And if they are, it turns out their brain is slightly different than the patients who are not. And that lets us make a choice as to how we're going to approach that patient with depression. And we do this for many different diseases. So for all these diseases, we do this machine learning, and we can get very good positive predictive values. And then we can use that, you see, so now we have positive predictive values that are known. We put these curated disease populations, these machine learned populations, into the same exact query tool. And now people can use those diagnoses that we know have a specific percent correctness. The positive predictive value is known in queries like this. We want to know if patients have rheumatoid arthritis really and are on medications, and we've done the sequencing for it. Now notice that doesn't have a plus or minus 3 because this is done with a provider that has privileges to see the limited data set, so they can get exact numbers back. That's important when you're looking for rare diseases. They have different levels of permission, right? So that for rare diseases, we can do special screening for certain providers, and they'll get to see the exact numbers. And that's a risk that we take. Here's how we can query the genotype data. Just like other data, we can drag the gene over, and we'll find all the patients who have variants on that gene. Or we can drag the variant over, and we'll find all the patients who have that variant. And so like here, you see we take dilated cardiomyopathy from the record, that's straight from the billing data. But we know that they have really congestive heart failure because we did that's the machine learned diagnosis. And then here's the gene that we're looking for, which in this case is the titin gene. It's the sarcomere in the cardiac muscle. And we want these homozygous and protein alterations so we can find those patients. So that's how we can take deep dives using the phenotypes and the genotypes of the patients to find very specific cohorts that we can then pursue in our personalized medicine. Then we create these distributed networks to increase our reach. So the eMERGE network, for example, allows us to combine biobanks. So we put the partners biobank in, but also a whole nationwide pool, of which we're just 2,500 out of 25,000. So there's 10 others, or there's 9 others, right? And so now we can do the same process with many, many more genotypes. We have another query called a network called PCORNet, which allows us to find patients across all these different hospitals in the country. And then, using this modular architecture, right, we can apportion out which hospital has the right number of patients. We can say, oh, okay, so let's pursue in Boston Medical Center the patients for recruiting them for a clinical trial. And then you see we go, and at Boston Medical Center, they have limited data set access. You did not have limited data set access over their whole network. Over the whole network, you see they're all the plus and minus, right? So they only have obfuscated access over the whole network. But when they're at the hospital, the specific investigators involved in the trial will get access at a limited data set level, and they can see one patient per line. You could not see this if you're doing a Shrine query, but you can see this at each hospital, by limiting it just to those patients that fulfill the Shrine query. And then those patients at your hospital, you can say exactly what their diagnoses are, you can see their exact dates, and so forth, so that you can screen them for that clinical trial. Okay, so finally, how are we going to get this back into clinical care? So we've been looking for something, a method to do this, because clearly finding similar patients, just the exercise, right, of finding similar patients in a tumor board, for example, kind of like referred earlier, so that you can figure out what the outcomes were for those patients and predict what medications would be the best, what chemotherapies would be the best, could be used in this way. But there's no real way that this research translates into clinical care until we invented something called smart apps. So smart apps are this way that we can make an app that looks like this, pulling data from clinical care. So this is how our current printouts look that say what your risk is given your lipid profile. Even I can't really figure this out. And I'm supposed to be a doctor, right? This is how the app looks. You see, it tells you, it gives you exactly what your different levels are. It gives you a little bit of important history, and then it'll give you a risk prediction. Patients can use this, right? But let me say, I like this too. This is the level I need the data, and I'm very, so this is very welcome for providers and patients alike. And we can scale this, so many different kinds of apps can be built to do this. This is an educational app. And you can post it in all these different platforms. So you can see how it's going to look in IPv2. Then we can put it into our electronic medical record. And this is a personalized health record. It's a record for the patients where they can see the data. And even things like growth charts can benefit from precision medicine. So here's a typical growth chart. And usually this is on a doctor's wall, and they give you a piece of paper, right? And they show you your growth chart. This kid looks like he's doing terrible, right? Or she's doing terrible, very at the bottom of everything and so forth. But if you analyze the data, and you take into account some very logical things, what's the parents look like, right? Are the parents short? Because if the parents are short, the kids should be short, right? Also, kids have different body profiles. So understanding what the weight of the patient is isn't just like a one-size-fits-all. So you enter this, and you get a completely different perspective on even something as simple as a growth chart. And now let's go into something more complicated in our last 2 minutes, which is, what's a kid's MRI look like? So you think, oh, MRIs are MRIs. No. An MRI is a picture of your fat-water ratio in different parts of your brain. And it turns out that when you're a kid, you're laying down fat like crazy because you're myelinating your axons. You're covering your axons with fat. The strands that communicate from one neuron to another, increasing the speed that the conduction occurs. What that means is that you're going to have MRIs that are going to get changed every day practically of a kid's life. So you're going to have to know what a normal MRI looks like in a kid. You're going to have to say, oh, well, what's it at 61 days? Well, nobody ever figured that out, so they're in the dark. So we actually went to the medical record and we collected all the normal MRIs that we could find. Now, normal is a phenotype, and it's a tough one for kids who have an MRI. Because why would a normal kid get an MRI, right? You don't just do random MRIs. So it was actually a very hard phenotype to do. And we got it down, so starting with 2,800 potential MRIs, we only found 700 that actually passed the phenotype. Here's an example, just to show you how much an MRI changes over the course of this same kid's life. This kid was a normal kid. I don't know why he got 5 MRIs. Parents were really worried about something. And the kids, they might not be normal. They might have something wrong with like their bones or something like that. But their brain and their development, we know is normal because they passed the phenotype. And then we can do this. Kids often, it's a horrible thing, but birth injury is one of the most prevalent things in kids. That is, you go to have a kid, the baby, for whatever reason, doesn't get born as quickly as it should. And the baby ends up becoming hypoxic. They don't get oxygen when they should. And you want to know, is that kid going to suffer permanent injury or not? And if you don't know anything about the MRI, you can't do an MRI and figure it out. But if you know what an MRI should look like at that day of a kid, you can do this. You can do the MRI, right? You can't really tell just from the MRI what's going on. But then you can do the subtraction from the normal. And it turns out, no, this kid is in trouble, right? So he's got this abnormality. Here you can kind of see it here, and indeed, this kid's in trouble too. This kid is totally fine, and this kid is totally fine. So what that says is you can infuse that then back into clinical care. You can do the same thing for management of things like medications and understand how to manage, is a patient taking the medication or not. Nice, clear data on yes or no, and it results in this kind of yes, they are taking it, or no, they're not. A nice digestion of machine learning, right for the clinician, but that uses all the informatics tools that you have helped develop. And so overall, this application of precision medicine, right? One, it's more than just genetics. It's about creating these tools and frameworks so you can make these kinds of clinical decisions. And it constantly requires new ways to understand how to use the data in this context of the patient and the security architecture that needs to exist. So lots of great people like you all as well went into building things like this, and there's something else. Thank you.